Hey, everybody. Thank you for joining us. Today we have coffee with the medical directors, thanks to CoxHealth Paramedicine and Mercy Health Paramedicine. First off, I want you guys to remember, please hit the like button underneath the video, and please subscribe to our channel. That helps us out and helps us keep producing high-quality educational content for you like these events. This is the first ever meeting of our local medical directors. On screen left there we have Dr. Matthew Brandt with CoxHealth Paramedicine, and on the right we have Dr. Tom Lewis with Mercy Health Paramedicine. Today we have a few questions from the field, from our staff and from local fire departments. And we'll go through these a little bit at a time and just kind of get a view of what our medical directors think. So first things first, we do want to give you guys CEUs for this. These will be online CEUs, not live CEUs. But to do that, we'll need you to go ahead and fill out an attendance check. On the YouTube chat line, you'll see a pinned message. It's going to be edu.coxcms.com/check. And you're going to enter your license number if you have one on that. Otherwise, hit other. And then your code that you're going to enter is 11462. 11462. We're going to do an attendance check at the beginning and at the end, and that's going to make sure that you guys get some CEUs for this. So, welcome, guys. Say hello.
Hello.
Hopefully, everybody can be heard. If you guys have any issues whatsoever, feel free to text myself. That's 417-239-9135. That'll be in the chat. And we'll get you guys reconnected or figure out what's going on. All right. So we have our first question for you guys. Or actually, why don't we just say hello and tell us how you guys are doing today, and give us an introduction, give us your background. So Dr. Lewis, will you go first?
Sure. Well, Dr. Brandt and I had been talking about trying to do something. It's been difficult with the pandemic to be in stations, be out in departments, and interacting with providers. And we were just talking about unique ways that we could try to interact with you a little bit more, so we could just sit around and ask questions. It's always a good time for us to sit down with crews, with providers, and just have conversations, whether it's around coffee or Mountain Dew, as many of them are in the middle of the night. And just kind of talk about cases or questions you have. So obviously the CoxEMS system put together this great program so that we'd have a venue to kind of talk to you here.
And I want to say that this is actually Tom's idea. We regularly have coffee, and we were like, we talked about the fact that it would be nice to invite people to our conversations and allow you to ask questions. So this is the culmination of that.
Completely agree. This is something we've been hearing from the staff, from both services, from the fire departments. This is something that we've really wanted to put together, and thankfully we've had the ability to do that now. So, you guys ready for some questions?
We're ready.
I'm ready.
Awesome. All right, so whoever wants to take this first one, why do we or do we not use end-tidal CO2 monitoring for nasal cannulas?
So I'll go first because the question starts out, why do we not use end-tidal CO2? And you do, and we don't. Okay. So the question is obviously like, why doesn't Cox use end-tidal CO2?
Okay.
For me, end-tidal CO2 is absolutely necessary for anyone who is receiving positive pressure ventilation. And that's an American Heart Association level of evidence, level of recommendation 1, you've got to have it. If you're providing positive pressure ventilations, it is a must-have. However, for patients that are breathing spontaneously, although the value can be useful, there was one study that showed that if you're in a spontaneously ventilating person, if your end-tidal CO2 is above 21, there's a 0% chance that you have diabetic ketoacidosis. That's useful. But in the average person, the waveform shape and actual value is it doesn't typically change the clinical course. And that's why we have chosen not to deploy this asset, because it is clinically, it doesn't change our practice. That's why we don't have it.
Yeah, and I can't disagree with any of that. You know, you look at how we treat a respiratory distress patient, and whether they're restrictive or obstructive, you're oftentimes following the same protocol algorithm. And so if it's just with a nasal cannula, I can tell you ours came about in a way to give us a secondary source of monitoring people. As a whole, we've been, over the last 10 or 15 years, we've been a proponent of being very aggressive with our pain management. And with that aggressive pain management, use of narcotics, comes complications, and comes the overuse of narcotics and decreased ventilation. And we use it when we sedate people in the emergency department as standard of care for us to see, because we see CO2 changes long before we see oxygen saturation changes. Somebody has a smaller tidal volume, we start to see that CO2 change. And so we began first after some complications, or at least suggested complications from delivering patients that then had some respiratory compromise. And so it was half defensive and half proactive about we could monitor people's ventilation a little bit better, but it also gave me a hard number that couldn't be disputed, that this person did not have respiratory depression while they were with us. I can tell you it's a costly asset to deploy. At times, those nasal cannulas can cost upwards of $20 per cannula when you talk about pennies for a normal nasal cannula. So the judicious deployment of that kind of asset is important, because you deploy too many of those and you don't get the things that really make a difference on how we care for patients, the long-term longevity of our providers. If you spend all your money on EtCO2 nasal cannulas, you have less power cuts and less auto loads. And quite frankly, I think those, you talk about patient care, people miss that is a core piece of patient care. If I don't protect the providers, then I have turnover, and I constantly have new 5-year providers. I want to protect those 5, 10, 15, 20-year providers. And so we have to weigh the benefits and risks of those. And so I can't disagree with your comments. Does it really change your protocol? Probably not. So, and our reasoning for why we've picked it up and we run with it.
And I agree with that. If you're saying that you are deploying this monitoring asset, I think that this probably would have prevented the outcome in Aurora, which was just settled last night or yesterday, which is the situation where an agitated patient or a combative patient, that's a different problem, but the patient was given a large dose of ketamine and subsequently had respiratory distress and arrest. I think that this is one of those things where it may have helped with that. So, to me, that pain control paradigm is great, and we give everyone as much latitude to control pain as necessary as possible. But pain control is, in the end, a customer service, and that's great. If someone thought that they needed more, we'd be open to that discussion. But at this point, we're not getting the feedback that we need to add extra. So again, just slightly different take on the same subject. So, all right.
Excellent. So kind of leading off of that one, our next question continues down that airway path. We have, what are the pros and cons of field intubation? Is it better for the patient than a supraglottic airway? And what patients do you feel truly need a field intubation? And can you provide an example?
I'm going to let you take that first.
Sure. We talk about this often together, because really, as the perception that we feel very differently about field intubation or those kind of things from medical director to another, we really have the same thoughts, and we just have this perception that we feel differently about field intubation. Field intubation definitely has its place. And early in our career in EMS or our profession, I think there was a perception, or we built the perception of inappropriate field intubations. It's like anything else. When you get a new drug, when you get a new procedure, sometimes the fact that you can do a procedure doesn't mean that you should do a procedure. And I think early in our profession in EMS across the nation, when it became more common that we did field intubations, I think at times we were probably a little too aggressive at times and kind of got that perception. And so the movement a little bit started to go away from the intubation. There's definitely a place for it. That person that can't protect their airway and has an aspiration risk, a vomiting risk, obstruction, I feel like those patients are appropriate for intubation. However, with adjuncts like iGels, in the last 10 years, we have seen the amazing ability to control or protect, or at least ventilate patients that previously we would not have tried. If we were having to bag somebody, they were intubated. And really, we have these decision trees that have gotten much more complex, like all of medicine for us in EMS has gotten much more complex, that you have to choose the right people. So when you talk about a specific example, somebody with vomiting over and over, lots of stuff in their airway, somebody that's obtunded, can't protect from aspirating that vomit, that's completely unresponsive, it's really hard to justify, from my point of view, that person should have an iGel. That person needs their airway protected, and that person needs a field intubation. However, there's a significant number of people that we put in a somewhat upright position that is minimally responsive. Maybe they have a little bit of some tongue movement, they're swallowing a little bit of their own secretions, but will tolerate an iGel. Those people ventilate completely fine, and we don't tend to run the risks of the aspiration as often. And so it's a complex world. I wish it was much more black and white, and I could say, this is the exact person you intubate, and this is the person that gets iGel, and this is the person that you bag. But like all of medicine, it's gone to a much more sophisticated
To about 2000, pre-hospital intubation was the standard of care. But starting in 2000, we started recognizing that the intervention we were deploying was not having the desired outcomes that we expected it to have. And we started developing new approaches. And that's where LMAs came from. Now, the old EGO, EGT, the dual lumens, there's a reason that they all went away, because they were more dangerous than intubation itself. But iGels and LMAs have proven that they are, and the American Heart Association agrees that now supraglottic airways are an accepted, not necessarily equivalent, but an accepted alternative to intubation. We were talking on the way over here that, and I haven't read the story, perhaps Tom can elaborate, but Mexico has eliminated pediatric intubations.
Yeah, New Mexico about 5 years put in their state protocols that they did not want ground or flight EMS intubating pediatric patients. So pediatric patients had to have some type of supraglottic or bag valve ventilation through their entire transport. And I can tell you, I was one of those 5 years ago that went, oh my gosh, the amount of kids you're going to kill, the appropriateness of this is horrible. And to this day, the state still touts that they have not had one complication that would have changed if the patient would have been intubated. So it's really kind of opened my eyes, and our teaching that you'll hear from us about kids can be bagged for a long time. Kids can get a supraglottic airway and ventilate them appropriately and safely. There's no reason to be super aggressive about intubating kids. And so that has really evolved just probably in the last 5 or 10 years in the nation.
And it's interesting that the paradigm shift began in 2000 with Lauren Gauch-Hill's paper in LA, that this whole change began with pediatric intubation, and here we are again. With regards to who should be intubated, I think that there is evidence that cardiac arrest that has a return to spontaneous circulation but has not regained a normal level of consciousness, if they are intubated appropriately, without hypotension and without hypoxia during the attempt, they actually have a slightly improved outcome. However, there are several cardiac arrests that you have a return to spontaneous circulation that recover also their level of consciousness. So if you intubate that person, you've actually compromised their ability to interact and perhaps even get into the cath lab once they get to the hospital. So again, a very complex problem, especially since it has known risk with not a lot of documented benefit.
There's some good documented detriment to it, right? We know, from some of now the pit crew CPR stuff and the stuff that had been published in the National Associated EMS Physicians Journal, the Emergency Care Journal, that really we found that in cardiac arrest, the people that got intubated early did poor. And I extrapolate from that, and lots of people have suggested the same thing, is that who does the intubation on a cardiac arrest? It's usually your most seasoned, experienced provider on the scene, right? Because you want this to go quick and well. So now you're going to take your most seasoned, the best trained, the most educated person on the scene and completely blind them to everything else that's going on. When we know that compressions and good ventilation are the things that make people survive. It's not our fancy monitors. It's not our fancy medications we're given. We know it's good compressions. And if the most seasoned provider can't keep his focus on, you need to go deeper, you need to go faster, really coordinating that code, those people are going to do poor.
Yep. Yeah, it's a change in priorities now. So.
Yeah, we even had a couple of comments in there. We had a couple of iGel lovers out there, and it looks like a drop in innovation since the iGel has come out, just in frequency. All right, question 3 we have. Dr. Brandt, why don't you take this one first? In your opinion, what is the biggest obstacle you foresee in EMS for Southwest Missouri over the next 5 years?
There are 2 major events going on as we speak right now. There's 3 amendments to the Title 19, Chapter 30, that would limit medical directors to 10 agencies. Where did this come from? And why does anyone think that that's a good idea? The Missouri Hospital Association has proposed legislation that nearly excludes or at least limits EMS's interaction at the state level in the development of time-critical diagnosis guidelines and development. In fact, the proposed Missouri Hospital Association language actually creates an advisory body that in power and scope exceeds the Board of Health. It has direct connection with the Department of Health's director. It's significant. So there are multiple amendments being proposed to the state law that have direct impact on us, like we would have to scramble to maintain what we currently have spent our careers developing. The other legislative part is EMS is excluded from peer review protection. Physicians, nurses, psychiatrists, nearly everyone in healthcare has a statute that protects them from discovering if they're going to do quality improvement. EMS does not have that. How did that happen? So I think that for the next 5 years, I think that the legislative threat is probably the most significant for me. Now, any crisis is a potential opportunity. So I think that that's also not only a threat, but a potential. And that leads into my larger industry, national industry beliefs, but I won't get into that just yet.
Yeah, I can't disagree that that's a huge obstacle for us. I also think not just in our region, but throughout the country, I think over the next 5 to 10 years, one of the biggest obstacles we'll have is education. Education is, by history, we've been a profession that had a short education plan. And if you look back 20 years ago, the majority of protocols were 20 to 50 pages long. And medicine has advanced to such a degree. We just touched on it from the difference of iGels, making the decision between BVM, iGel, and intubation. It wasn't, oh, their GCS is less than 13, I'm going to intubate them, or less than 11. It's just black and white. Medicine has gotten much more complex, and we're asking more of the pre-hospital providers. That I think a big obstacle for EMS in general will be trying to keep up with the loads of information and the loads of research that comes out, and the changing education demands that will be asked of you and asked of us to provide to providers, because we're asking, at least you think about 20 to 50 pages of protocols 20 years ago, and now we're 100, 200 pages of protocols and policies. For a typical ALS EMS agency, we're asking so much of you, of the providers, that I think it'll be a big obstacle to continue to provide the education that you deserve and that you need to, practice modern medicine in the field.
And let me expand on the education theme that, and this gets to my national industry level outlook. One of the reasons that EMS was not in the 1A group for the vaccinations is because EMS is not seen as part of healthcare. So we are the most patient-facing, direct threat that this pandemic had. And yet we were put in the same category as not doctors, care profession. And we do that through education. And we do that through, we need to become, an associate's degree. A paramedic should be an associate's degree. And there needs to be a professional development from EMT, which is paramedic 1, through paramedic, and then a leadership track that develops the industry as a professional organization, independent of public safety. We are healthcare. We are not public safety. We are the part of healthcare that interacts with public safety. But again, getting back to the legislative component, this is interesting. This is one of the most interesting things. EMS is controlled by the Department of Health, but yet in the majority of EMS organizations in the state of Missouri, they're controlled by the Department of Public Safety. The fire department controls EMS, and yet EMS is controlled by the Department of Health. This is an example of how confused we are, and this makes
it difficult to answer to two mothers.
Right. So education is how we begin changing the structure of the industry.
But that's a huge hurdle for our providers, because compared to 20 years ago and now, there's a lot more asked of you. And we understand that, and we're striving hard to keep up with the education you deserve.
Yeah.
Excellent answers, guys. We're going to go ahead and take a 5-minute break real quick. That way everybody can get their coffee, and we'll come right back. So thank you for attending, and we'll see you here in a couple minutes. All right, welcome back, guys. Hopefully you're still with us. Give you just a second or two to put whatever you're doing down and get back with us watching the stream here. Dr. Brandt did receive a question during the break, and I think he wants to go with that as we get started again here. So go ahead.
So the question was, if EMS is part of healthcare, should EMS education be within a public safety envelope. I think that the opportunity for a broad educational exposure. People, if you're an 18-year-old person and you're looking for lights and sirens and that kind of thing, EMS is an attractive thing, as well as fire protection and law enforcement. Plus, a lot of our core educational requirements are the same between law enforcement, fire protection, and EMS. So I think that having it within public safety, as opposed to having it within healthcare, is beneficial. I think that it increases our recruitment and provides, perhaps, because law enforcement and fire protection are already ahead of us in professional development. So co-opting their structure is in our best interest, at least in the short term. So yeah, I do think that having EMS within public safety and then providing a professional development track through EMS into whatever, there's EMS leadership and then there's progression on in healthcare. So I think that although we start in the public safety sphere or environment, having a professional development track that leads you to a broader opportunities is part of the program.
I agree. Your core understanding of how you operate in the field is so foreign to the rest of healthcare that you'd be dragging a significant amount of education into a healthcare sphere if you started EMS there. Now, we've already established that this is a healthcare profession and should be educated like any other healthcare profession. But yeah, it would be very difficult because all of those scene safety and how you interact with law enforcement and fire scenes and all those kind of things that are core to our profession would be completely lost on the rest of healthcare.
Yeah, and look at the EMS agenda for the future 2050. We are the part of EMS is the part of healthcare that interacts with public safety. So, starting our education within that community is appropriate. So,
Awesome. Now, leading off of the last chat that we had, or the previous question, we received one in the interim that was, how do you combat the staffing issues in the next 5 to 10 years for EMS? Dr. Lewis, why don't you take this one first?
Well, I think it's going to be difficult. I think we have a fair amount of turnover. Because we're already talking about the added education need to provide appropriate care, more like a healthcare provider rather than just as we have in the past from a highway traffic safety standpoint, that with more education, ultimately is going to have to be followed with professional development. There's got to be a stepping stone for you to move as a profession. With that comes increased wages to combat that. And with more education, there's a reason why Dr. Brandt gets paid more than somebody that's not a physician. For the same reason, if we're talking about the need for more education, comes more input, more time, more investment, more education. The salaries are going to have to follow that. I think there's been I think we'll see in Southwest Missouri a little bit more move to use the entire spectrum of EMS. A lot of, in our community, we've been really lucky over the last 20 years to use all ALS trucks in a town like Greene County or some of these smaller communities. And I think we're going to have to use people all the way across the board. EMTBs, advanced EMTs, paramedics, to the full scope of their practice to provide this extended continuum of care to meet this demand.
So the staffing issue implies that we're going to have, to me, I take this question as we're not able to fill seats. So with that is absolutely essential. equivalent pay. In a fair market analysis of our area, we're behind when you compare it to the industry, etc. But you can't ask for more pay without having a professional, without deserving it, not that we don't deserve it, but without a demonstrable qualification. And that comes from our interaction with Medicare and Medicaid. So pay and retention is clearly a big component of meeting our staffing issues. However, my approach, my proposition is that we put an increased emphasis on recruitment. If I'm an 18-year-old kid and I'm considering the military, and one of us walks up to him at a job fair and says, if you sign here, we will put you through school and we will pay you, and in 10 years you could be a nurse, PA, doctor, debt-free. And you'll come out with this tremendous experience in all these opportunities to cross-train in law enforcement and fire protection, etc. There's one approach is to maintain your staff numbers, and another approach is to fill the pipe. And I think that that's an undiscovered opportunity yet. We're not able to hire people that are under 21. That's because of our insurance issues. That's killing us. So I think that pay and qualification for pay is terribly important, and we have to move forward on that. But we can't neglect the recruitment aspect of this issue, and I love that part, and that's education, again with education. So
Well, maybe to feed off of the monetary issue we just talked about, one of the questions that was asked, I think, is advancement of technology. There's been talk of Aed Drones. Is that something you see in our area?
Somebody will deploy them. Somebody will deploy them.
They're on order. They're on order, but the COVID is backed up the supply chain. So that's actually part of the EMS agenda of the future. If you read that article, if you read that the illustrative component of that, it's in there. So I'd love to see it. But.
Yeah, I love the sexiness of a AED drone, but if you look at the numbers as a whole, the AED deployments around cities have not increased the number of saves significantly in compared to public education of bystander CPR. So as cool as an AED drone sounds, us continuing to be part of reaching out to the public, and we are the perfect face for that in EMS, and teaching people hands-only CPR and things like that are going to save more lives.
Yeah, and that's it. If someone were to ask me, what could you do, and I think this is one of the questions that was proposed, what could you do to improve survival in the community? And it's public education, and it's not only public education, but it's public empowerment. Or, you could say that, making it compulsory. You need to be able to do CPR in the public to graduate, to get a driver's license, whatever. I mean, that's extreme, but more public interaction, more public involvement in the public's health would be a huge benefit, as opposed to spending money on AED drones, which is very sexy.
Super cool. Super cool.
Well, then maybe on the talk of retention and staffing, if you were in charge of EMS for the future, how would you build a career ladder, and how would you create the career ladder that would improve the retention of the EMS community?
Who's going first? I'll go first.
I love it. I love this.
Yeah,
I love
dude, I mean,
this
this is my favorite component of EMS. So how would you build a career ladder? Let's start that. What is the career ladder? What would it look like? To me, it starts in this core education, and that core education is pretty common among nearly every professional organization. But then you develop your, National Incident Command System. These are all common things that are specific to public safety. And then you do the EMS 202. paramedic and EMT, etc. But then you get into leadership classes, and those leadership classes involve cross-pollination. So you've got EMS people going to structural rescue, and you've got police going to EMT, and you've got, this at that 300 level, you've got multiple leadership interactions. Where the leadership, the LPO, leadership police officers, we have EMS and fire involved in these classes currently here in Springfield. But then creating a bridge. Once you reach a certain point in public safety or EMS, creating a bridge that leads to additional opportunities like nursing, PA, physician, etc., or some other hospital administration.
Health administration.
Absolutely.
Right. Masters in health administration and all these kind of things are all part of that. Your ability to work with the public and talk to people, it's crazy for us not to think that your career path wouldn't also entail interaction with the public from an administrator point of view, a hospital administrator, your understanding of a health system. There's very few people that step in every department in healthcare, except for EMS. You ask where to go in a hospital, and 75% of them go, I don't know, I just come here every day. Ask a EMS provider. They'll go, oh yeah, go up these stairs, it's to the left. Because I've been everywhere. I've had to take care of people in every department, and I know how it works. So I agree, that career path step, I think also very much promoting people in leadership roles within EMS as well. I think as a whole, we really have to grow our own. This mentorship, for a long time, EMS sometimes has a feeling of general surgery for physicians. General surgery is this place where you eat your own. You eat your young. You just berate people and beat them down and tell them how horrible they are to try to make them better as surgeons.
And if there's any general surgeons in the audience, we still love you, but
we do love you, but we know the environment you grew up in. It was ugly and horrible. Being a mentor and showing people how you take care of people, how you grow as an individual, and how you lead people. Growing people within our own organization opens up all those, the field training officers, the shift supervisors, all those kind of things. So as you grow, you have stepping stones at any level, at an EMT, at an advanced EMT, at a paramedic level, that all those positions are available for you to continue to grow, as well as the education you talked about.
Yep. That's what it's all about.
Excellent answer, guys. So this one's going to take us a little bit off the beaten path. So this one was asked, it says, you found an old dusty urinal in an ambulance. You brushed off the dust and skin flakes, and a genie in the form of an old crusty medic pops out. And it says that they'll grant you 3 EMS-related wishes. For each one of you, what would they be and why? Dr. Brent, go first.
I disagree with the format of the question. Why would an EMS pop out of a urinal? That just presupposes. That's not. Let's pick a different vessel.
There's no crusty EMS provider.
That's right. That idea is antithetical to the vision that we're trying to create. Okay, 3 wishes, huh? First would be peer review protection, or what would be even better is linking pre-hospital treatment with patient outcome. That does not exist, except for a couple of papers. Creating that link has proven nearly insurmountable. The hospitals don't want to give it up. EMS, fire-based EMS is siloed by HIPAA. So creating a link between pre-hospital quality improvement or pre-hospital interventions and patient outcome would change of EMS practices based on evidence. That's got to change.
I would agree with that wish completely. If we had a better ability to see what we do in the field makes a difference, that amount of education, that is a huge wish. That if we'd get that feedback, And really, medicine has changed in the last 20 years. Medicine in the hospital has gotten much better, in the emergency department, in surgery, has gotten much better to connect those dots right back to the link of, oh, if I do this, this person gets less infections. If I do this, this person gets better. And we have not made that link very well in pre-hospital care because of all those things you described. So 100%, that would be a huge wish.
Because we're not part of healthcare.
Just make that link. I'm good.
Yeah, right. Second thing for me, take EMS and put it squarely in healthcare. Instead of having one foot in public safety or the Department of Transportation is where EMS rests right now in a national level. Why does that happen? So take EMS and create a home in healthcare. I think that would be the big number 2 for me. One, and if I didn't get that, I'd still have the evidence to guide my development. So number 1, evidence. Number 2, put EMS squarely in healthcare. And number 3, I think we've beat this horse to death, is the development of a professional development ladder. Those are my 3.
My second wish would be to funnel more funds to EMS. Not for fancier equipment, not for drones, but you hear about hospital administrators, healthcare insurance providers, getting their yearly bonus of $6 billion or whatever it is. They get their each provider's getting their, or each health insurer CEO walks away with $5 million. Turn that back. Make us do a little bit more education and quadruple our salary. We are as EMS, you practice emergency medicine just like we do in the emergency department. And I ask the same decision trees from you. I ask you to make the same life-threatening decisions or decisions whether somebody's going to survive or not. You should be compensated appropriately for it, but at the same time, more of the healthcare dollars should be funneled to us so that you get paid quadruple what you do for the amount. It's crazy to me, the person that is going to make a difference, whether my mother or father survives in their home, whether they're going to live to talk to me another day, is the guy that is paid the least amount, guy or woman, paid the least amount in the whole healthcare chain. Doesn't make any sense. So that is a big wish for me.
And we can't do that.
Turn those back into it.
And we can't do that until we become more professional and separate ourselves as healthcare professionals. So
absolutely,
it goes. All these things go hand in hand. And I absolutely, I say this all the time. Name that profession. People seek me out with a medical complaint. I do a history and a physical. I come to a conclusion and I institute treatment. Who am I? The obvious answer is a physician. No one else in healthcare has that responsibility or scope of practice. Nurses, physical therapists, no one. Physicians and EMS.
Yes.
And yet you've got the highest paid, highest protected, and EMS.
So
it's terrible.
Yeah.
It's
so I guess
terrible.
To bear it all down, pay you $1 million.
No copyright intended.
and give you sharks with laser beams. Yeah, that'd be awesome.
Those are excellent answers. Thank you, guys. That was a strange start to a really good question. So the next one ventures into specific protocols or specific ways of doing things. So are there going to be updates to the TXA guidelines to keep in line with the new TC3 guidelines? The suggestion here was the 2 grams of TXA for normal indications in addition to suspected head traumas.
I'll go. Mm-hmm. You want to go? All right. Especially with the British. But there's no evidence to support that practice yet. The first good randomized prospective control trial that comes out and says that 2 grams is superior, that afternoon we will switch to 2 grams. But that evidence is not there yet. As far as head injury is concerned, dude, at this point, I just settle for giving it to traumas. We're struggling with that. So, again, and I've said this before, and I just want to put it in public. When chest pain started with aspirin, we knew that there were going to be some problems when we gave the general population with a chief complaint of chest pain, if we give them aspirin. Yes, if you've got erosive gastritis, you just didn't help that person. But we did that with the knowledge that for the people that were having ACS, it would help. Aspirin is to chest pain what TXA is to trauma, and we're not there yet, and we need to move forward with that idea. But as far as changing the guidelines yet,
And things are moving super slow, and they will continue to move slow because they don't have the big pharma numbers or dollars to push it. You know, this is a cheap medicine. And so even though we want it today, we want the evidence today, we want the research today, this is one of those that is going to drag out over the next 5 to 10 years because there's just not a lot of cash behind it, which, you know, I don't know what to do other than call a duck a duck. It's going to take us a little time until we know for sure. But we know for sure that people do well with multi-system trauma. So we still push that.
we did a retrospective analysis of the patients who came to the Cox emergency department who met the CRASH 2 criteria for TXA. And of the 200, and this is, the guy who did this study is actually in medical school right now, and I wish he was watching. But we found that of the 275 patients that were eligible, two patients got TXA. And if you look at the factors that influence decisions whether to give or not to give, it's all operator headspace. They're just not thinking. They're not thinking, hey, this person needs TXA. They're all getting IVs because IV, they know that they've got to have an IV for whatever reason. But they're not using it for anything. They could use it for TXA. Aspirin is to chest pain what TXA is to trauma, and we need to move forward with that.
And we really, you know, from our service side, I think we really made it more complicated than it needed to be. We asked them to give the initial bolus, and we asked them to start the drip. And realistically, we know the short transport times that we have. We're not having 6, 8, 12-hour transport times. That drip can be started in the hospital, and so we've stepped back to try to make it easier. Just give them the bolus.
Yeah,
That'll make a difference.
There's a question here about slow, fast, or slow or fast. The FDA recommends the 10-minute drip because of the idea that it causes hypotension. We have to avoid hypotension, and we should continue to follow the FDA guidelines. So I think from a legal perspective, I can't really advocate. However, let's just say that we'd be really happy if the trauma patient got the drug.
Absolutely.
That's the thing. I'm not gonna argue over what color the horse is when I'm trying to get somewhere. Just get on the horse.
Just
man.
trying to get on the horse.
Yeah.
Awesome, guys. I really appreciate that. We're going to go on one more 5-minute break. This will be the last break before the third and final set of our Coffee with the Medical Directors. So stay tuned. Stay with us. We'll see you in a couple minutes. All right, guys. Welcome back. Thanks for sticking with us. We have one more set here and a few more questions. Feel free to add your questions into the chat. We are using them. So leading back, before I get into that, just viewing this event, but moving on to the question. The next question we have for you guys, what are your thoughts on establishing a tax-based entity that would allow double medic ambulances or partnerships with fire departments? And why not just put more chase cars on duty to backfill the staffing issue?
That's a two-part question.
Yeah.
So let's talk about tax-based entity first.
Yes.
You know, we live in this huge, you know, you cover 3 states. I just cover, you know, a broad swath of our operational area. And we have crazy distribution of payer mix, whether it's tax-based or fee-for-service or hospital-supported, etc. Again, we're talking about the consequence of our failure to establish an identity. If we're public safety, we should be tax-based. If we're healthcare, we should be Medicare, Medicaid, fee-for-service based. And our pay mix is a consequence of our confusion. So until that, yeah, it's great. Let's get some tax-based stuff. I'm a little worried about the impact of moving in that direction will have on our future. But yeah, if you can get that done, our tax-based entities are phenomenally more successful than our fee-for-service-based entities.
I agree. It gives, tax base right now, Medicare, Medicaid just doesn't pay enough for most EMS systems to survive. And it's that identity problem that we've run into, that we're kind of healthcare stepchild, that again, you make these huge critical life decisions and diagnoses on people, yet the reimbursement for that is one of the worst in healthcare.
Yeah.
And so until we fix that, we'll always have this discussion about whether it should be tax-based. Because on the short term, it's an easy number to say, oh yeah, we should be tax-based because we'll get more dollars in. More dollars in also oftentimes becomes more political. And with more political, then the true evidence-based medicine sometimes gets a little bit muddy. Ask a major city fire department in east of us or north of us, unknown names, how political their protocols get when they become tax-based.
Yeah. Oh, look, I found my soapbox. Let me get on it for just a second. So one of the problems that I see with doctors, and this is just my personal, analysis over the past couple decades, but doctors want to be politicians. I mean, we want to move into the administrative area because those decisions directly impact our life. But we're bad businessmen. I mean, doctors are in business to go out of business. I mean, we would give away our stuff. But so the business side never really engages with us, or we have difficulty engaging the business or political side. But what we have is data. We analyze data. That's our whole shtick, man. That's our jam. But yet in EMS, we don't have data. So we're fighting as businessmen and politicians when we should be fighting as the doctors that we are with the data that we can't get. All right, so the step off my soapbox is very short.
So the second part of that was double medic trucks, which has its own pluses and minuses. I can tell you that from a Mercy standpoint, we ran double medic trucks for a really long time. And I like it from the fact that it protects you in a busy system, that you're not taking every call. But in reality, I would a lot rather our fleet management and our asset management protect you, rather than you having to be paired with somebody with your same skill level, same pay scale. It'd be kind of like, well, every person that comes into the ER gets Dr. Brandt and I in the room. We're going to double dock every patient that comes in. Sometimes it is helpful to bounce that question off somebody or talk about a diagnosis, but realistically, at a ALS level, you're the highest. So I do want to protect you, but I'd lot rather our asset management protect you rather than protect you by just doubling up your truck.
And if you look at the evidence, having an ALS service in an area that has a short transport time is not necessarily value added. It doesn't improve outcome, at least with the limited data that we have right now. If we had more data to guide the development of that, if we had one study that showed that putting double medics together, we'd do it that afternoon. But we don't have the data. And at this point, in urban areas, having a chase car or one paramedic is, that may be more cost effective. Again, the outcomes-based evidence and the operational evidence, we just don't have that data to support any of that decision. We're just deciding what color we want to paint the sky.
Awesome. Thank you, guys. The next question we have is for each of you, what is your background? Tell me about you. What led you to be interested in paramedicine? Why are you the medical director for your agency? Tom, why don't you go first?
All right. So I in college, when I decided medicine was the right thing for me, you know, I was drawn to EMS. I actually was enrolled in the Sedgwick County EMS program to start in when I graduated from college, while I was interviewing for medical school, and got into the University of Kansas Medical School and missed that opportunity to start at that time. So at that point, I always had kind of that love for EMS and being around those, whether it was from summers being around and spending time around, you know, health organizations. I worked on a Air Force base a couple summers in college and did a lot of the CPR training and safety instruction and stuff like that for a third-party company for an Air Force. And I always wanted that kind of connection. So when I went into medical school, my decision to go into emergency medicine was really kind of based on feeling like that niche, that itch was never scratched for me. I never got to work in that pre-hospital arena. So emergency medicine was one of the few specialties that still allowed me to work pre-hospital. And so I chose a residency that had, at the time, a track for EMS. I'm old enough that there were not a lot of EMS fellowships, or at least not a lot of certified EMS fellowships. There were only a couple in the country. And I went up to Michigan where I could work a lot in EMS. And so I went to a program that allowed me to be a flight physician on a flight program. So I got to fly, got to work ground quite a bit, got to work with law enforcement with police units and stuff like that throughout my residency. And so always had that connection. And so when this availability came up, I was already working with EMS before this job description came up. Ever since I moved here to Missouri, I was working with our tactical team and some of our special operations teams because of my love for EMS, and then the availability to become the medical director arose. So that's my background and my connection to EMS.
I would say that the reason that I'm in EMS is mental illness. I'm just slightly mentally ill. And I'll give you a perfect example. So, I'm 7 years old and emergency's on, and I just loved Roy and Johnny, and I just wanted to be Kelly Brackett. I just thought Kelly Brackett was the coolest guy in the whole world. And the fact that he's a cardiothoracic surgeon who had nothing better to do than answer that radio is just awesome. I was personally devastated when emergency was canceled, and that had a big impact. My dad was one of the first CPR instructors in our town, and taught emergency first aid and would provide medical support at the local ski jump, which was a big thing in Iowa, ski jumps, water ski jumps. And so I just loved it. As a medic, and I loved that. I couldn't stand the Army, but I loved being the medic. So I actually left the Army early because I got accepted to medical school, and this was and one of the things that got me into medical school was the fact that I loved pre-hospital or out-of-hospital medicine so much. And that's another thing, is that we are currently seeing a convergence of pre-hospital or out-of-hospital medicine, whether it's tactical medicine, disaster medicine, event medicine. All of these things are converging either at SOMA or some other agency, and that's just something I love. I love all of that stuff. I love working in the emergency department because I really get to flex in that environment. But really, from the time I was 6, I got in trouble in kindergarten for taking first aid kits to kindergarten, putting Band-Aids on people. And that's just odd. Come on. So, but that's never gone away. So this profession is unavoidable for me. I don't think you could keep me out of it. No way.
You were both clearly destined to be in the positions that you are.
Yeah.
All right, now we get real serious. Looking forward, especially in our current political environment, how does healthcare reform impact EMS? And for example, the talks about a single payer U.S. system?
You go first.
I've been in medicine, a little around 20 years now, a little over 20 years. And I don't know. I don't have a lot of hope that this will ever go to a single payer system. But we've talked about our hopes for healthcare reform. Really, those dollars really need to be redistributed. We spend a lot of money for some of the best healthcare in the world, but it's horribly distributed. It's distributed very heavily in drug companies, in health insurance companies, in administration, where if you funnel more into the workforce, into the people on the assembly line, those are the companies that invest in the assembly line, make the best product. And if we can't change reform to funnel this more towards assembly line workers that are actually taking care of patients, I think we'll have this conversation in another 10 or 20 years.
Yeah. If in the United States, our healthcare system is designed to address those people that are ill or injured. And with that regard, we're unmatched. Where we suffer is just like you're saying, we don't have bystander involved CPR. We don't have incentivized health. Incentivizing health. That's one of the things about the Affordable Care Act was healthy people are cheaper. Healthy people have less financial impact on the outcome, on financial burden. I agree. I don't think that we're destined for a single payer system. I just don't think that the American public are ready for that. However, there is, with a single payer system, I'm always looking at, the potential benefit of any crisis. What would be the impact of a single payer system on EMS? Would we be pulled into healthcare? If that were a consequence of that, boy, I'd have a hard time. I would prefer not to choose that course of action, to go down a self-payer system just to meet that need. But, it's one of those things I'd have a hard time sacrificing my dream, of putting EMS in healthcare to just for a cut in our salary, probably.
Yeah. Sorry, I know those are vague answers to a very difficult question.
Yeah, that's a big global issue.
That's a political, and it has so many variables. So we appreciate the insight that you could bring to that for an answer, though. Why don't paramedics practice in ED alongside doctors outside of school? I feel like if I were to retain...
So, in the past, paramedics worked as nurses. They didn't work alongside doctors as doctors. I think having a paramedic as a physician extender, or perhaps even I hate to say this as a scribe, but if the desired end state is improving paramedic exposure to physician thought process, etc., linking them to the doctor is the key. Putting them in the ER makes you, putting a paramedic in the ER makes you as much a doctor as sleeping in the garage makes you a car. It just doesn't work. But the key is to link the paramedic to the doctor or the EMT to the doctor. And how do you achieve that goal? That's the thing. So practicing, again, as a paramedic, you can't practice. You're just not legally allowed to do what we want you to do. So that's my answer to that question.
Yeah, and I take that question as it weighs heavy on both of us. I think this is why both of us are involved in more extensive chart review than a lot of you are, because that's our best time-efficient way to practice with you. Is go, hey, I probably would have thought about doing it this way, or did you ever think about doing it this way? The same things we would have done if we were working side by side in the emergency department. And I think the onus of us being involved as much as we can from on the scene, from medical direction, and interacting with you, This is our best way of working alongside of you. And I agree. For you to, and I think many people in EMS have found, for you to take that track and become a nurse, they do an amazing job of taking care of people, but it's a different skill set than you have. You know, the decision making that you make in the pre-hospital arena is very much just like the decision making and the decisions and the choices we make in the emergency department. So I would love for you to come work beside me. But my alternative or my fix for that is I need to be working beside you in your world, or I need to do the best next step is talk to you about as many cases as I can of your world, about what did you really see? Well, what did that make you think? Well, I would have thought about this, those kind of things. So I appreciate the question, and it kind of just tells me I need to get off my recliner and come work with you.
Get off our big chairs here.
You're still in your recliner.
I know.
But
I know what you're saying. Get off your recliner.
Yeah. Increasing the connection between doctors and paramedics is key. Putting you in the ER, I'm not sure would lead to the desired end state.
Very good. On the topic of that more advanced care or additions to our care, one person asked, what about carrying iStats on the ambulance or even ultrasound?
So I'll go with
Those are good
iStat. I'll take care of the iStat thing. So the iStat is the injectable hemostatic sponges.
Or are they
No,
talking
the labs,
the pre-hospital labs.
Sorry. iStats. The problem with iStats, the problem with laboratory results is that they're governed by CLIA, and in order to maintain that, it's just onerous to maintain the standard so that it's acceptable. Plus, if there were any laboratory result that changed pre-hospital decision making, we'd have it. It just doesn't change anything.
Yeah, I think it's difficult too. You know, when we look at iStats and the cost-benefit ratio, once again, I'd a lot rather protect you and keep a provider for another 10 years with your experience to take care of somebody and pay for an auto load system and a power cot than I would to spend for one iStat. They're expensive. The CLIA certification is a pain and takes a lot of money and training, but it's tough when you start weighing that risk-benefit ratio or benefit-benefit ratio, knowing that they have a hemoglobin of 5, well, until all of us start carrying whole blood, that doesn't fix that. Knowing that their troponin is 40, your ability to read an EKG is what I need. Your ability to read a person and their presentation that are in their brain in the pre-hospital arena. We might be at some point, and then
Germany,
there's going to be good reason to have those. But once again, when you talk about the benefits of each, I'd a lot rather funnel my money to keep you, the experienced provider, on the street working longer, picking up on that person's subtle presentation of their heart attack, not an iStat.
Yeah, but just to back to, XStat is the injectable sponges, iStat is the lab. So, and ultrasound fits in the same thing. If ultrasound had changed our practice, we would have it. I mean, we would have it. It just doesn't change anything. It just doesn't change the decisions that we have to make in the out-of-hospital environment.
We use ultrasound on trauma to see blood in the belly. It doesn't change the fact of what's ultimately, we still see them in the emergency department. They still get all the same treatment that you would give them. And they typically either go to the CT or go to the OR from the room that we do the ultrasound from. Ultrasounds for their vena cava that tells us that, or their ventricle that tells us that maybe they're pre-renal or don't have enough volume. Well, quite frankly, we know those before we put the ultrasound on. I'm putting the ultrasound on, so now I have two sources. Yes, I see this person is dry. They have a history that makes them dry. I'm going to give them fluid. My ultrasound is just one more thing I get to document. It doesn't really change that emergent, immediate care that we provide. And again, for the cost of one of those, we can keep you on the street working longer.
Or increase your pay.
Mm-hmm.
Yeah. So, anyway.
All right, guys, I have one more question, but before we do that, I just want to remind everybody to go ahead and hit like underneath the video. That helps us out. Hit the subscribe button, the little bell on your YouTube channel if you want to see more things like this and be notified when we put more content out. Also, I'd like to say thank you to some of our staff here that makes this all possible. First is Brandon Foster, our producer, running the stream that you're looking at. We have Aubrey Johnson as our operations. And then we have Jessica Estes and Alex Scharf running our moderators, the people you're interacting with on the chat. And then, of course, thank you to Dr. Tom Lewis of Mercy Health and Dr. Matthew Brandt of CoxHealth. I do want to tell you to join us for our next CoxHealth Emergency Responder Training Series. This is a live, YouTube live training, 4 hours of CEUs. This will be on March 18th at 0900 hours, 9 a.m. That'll be time-critical diagnoses and shock with Owen Aldridge. And then look for us next quarter for the next Coffee with Medical Directors. We have one more attendance check I want you guys to do before this last question. So go ahead and hit that link at the top of your chat or edu.coxems.com/check. Your code that you'll need to enter is 22768, 22768, and that will be added to the chat. So I'll give you guys just a second so you guys can enter that. And then we'll ask our final question and close out with you here in just a few minutes.
I can't wait for this question.
This is the good one. So.
I'm ready to jump at it here.
So our final question, we just have a little fun with this one. So who do you most relate with? And these are all going to be TV doctors. So Dr. Gregory House from House, Dr. Steve Hardy from General Hospital, Dr. Leonard McCoy from Star Trek, Dr. Hawkeye Pierce from MASH, or Dr. Doug Ross from ER. Dr. Brandt, you seemed excited to answer this first.
I choose not to pick from the list.
Oh, I was going to do the same. All right, come on.
Kelly Brackett, man. Kelly Brackett. I love Kelly Brackett. Kelly Brackett is my hero. I mean, especially if you have the time, watch the first episode of Emergency where Kelly Brackett goes and talks to the California legislature. It's really phenomenal. It is the argument for EMS. So Kelly Brackett's mine. I choose not to choose.
More with Handy Manny than I do Steve Hardy, because it's just, I feel like most days, like in EMS, we're just trying to make things work. I feel much more like a handyman than I do identify with a physician. You guys are given a limited number of tools to take the best care of people, and I think from our community standpoint, Southwest Missouri, you do an amazing job like that, and that's who I identify most with, as more of a tool time or a handy manny, just making things work the best we can out of what we're given.
Excellent answers. Again, thank you to everyone. Thank you to our the people who made this happen. CoxHealth Paramedicine Education, our education manager, Russ Scanlon, and our director, Mark Alexander. Thank you all. Say goodbye, everybody, and we'll see you next time. Appreciate it.
Thank you.
See ya.